It's about 8:02 on the first Tuesday of the month of April. Today's date is April the 5th, 2022, and I welcome you to this edition of the First Tuesday program for the Maryland Resource Parent Association. My name's Arnie, and I have the privilege of being the host. Tonight, I'm joined by Amy Wolfson and some of her colleagues who she will be introducing. I met Amy probably 2 years ago before the pandemic shut everything down, and we've had multiple conversations across the course of time since then. Most of them have been around sleep and how it affects foster kids. She and her colleagues have been studying that issue, and I think that we're joining tonight in hopes of finding out some information about their study and how we can use those findings to help our kids and in some of our cases ourselves, because we have problems sleeping as well, probably, or finding time to sleep. And that, I know that is not the topic of her conversation tonight. So welcome, Amy. I'm glad to have you here. I know that we're interested and excited to hear and see what you have to share. So you are already the host of the meeting. I know you're going to share your slides, and then you will send me a copy afterwards, which will be attached to this conversation on the MRPA.org website under the resource tab. So thank you all for joining. If you haven't already, put your name and jurisdiction in the chat so that we can get credit to you for this training exercise. So thank you for joining. Thank you, Amy, for being here. Thank you for bringing along your colleagues. So with that, I'll turn it over to you, and I will mute so you are not entertained by my dog.
And hopefully we won't hear my dog. Thank you, Arnie. Thank you for such a lovely, warm welcome. I'm going to go ahead and share my screen, my slides. So just one moment. Okay, just one moment. Okay, hopefully everybody can see our slides. And yeah, we're going to talk about sleep for foster care children. And certainly we're going to talk both about kind of in general children and particularly focused on preschool and school age children, although a lot of my work more in the general population has to do with adolescents. So when we get to the Q&A, I'm happy to answer questions about adolescents as well. And yes, I'm Amy Wolfson. I'm a professor of psychology at Loyola University, Maryland. I've been there since 2014, but spent a good bit of my career at another Jesuit Catholic institution in Massachusetts. So I'm a bit of a New Englander. And I've devoted my entire career to children, infants, children, and adolescent sleep and daytime functioning. And with me here, I have Josie Nogales and Maddie Valentine. They've been working with me. Gosh, they're about to graduate in a couple of months and been working with me. I've met them as first-year students, and they joined my research team when they were second-year students. So they are quite knowledgeable. And in addition, just a little bit about each of them. Josie will be going on to get a PhD in clinical psychology, and Maddie Valentine will be going on to get a PhD eventually in neuroscience, cognitive neuroscience. So they're some of our best students. And they're going to talk. I'm going to talk first about kind of in general, provide some background regarding preschool and school age children, kind of sleep needs, sleep problems, and how you can sort of work with children under your care. And then the second part of our kind of evening, Maddie and Josie are going to lead you in sharing some of our findings from the work we've done actually collaboratively with colleagues at two additional institutions, three institutions, Dr. Candace Alfano, who she herself was a foster care parent and now has adopted a child, and she's at the University of Houston. Dr. Ellie McGlinchey, who is at Fairleigh Dickinson University in New Jersey, and Dr. Carol Ripple, who works with a national organization called Pajama Program. You may have come into contact with the program. It's a nonprofit that's been in existence for about 25 years and works to provide books and positive bedtime routines for children around the country. So let me talk first about the importance of sleep. And your colleague and friend Arnie is right that I certainly am going to although I'm focused on children under your care, sleep is important for everyone. We often forget that, or I need to remind everyone that sleep is as important as two other health prongs. If you think of kind of a three-legged stool, nutrition, exercise, and sleep. A healthy lifestyle really needs to include quality sleep. And certainly in the short term, we all know, whether it's for adults or for children, that lack of sleep or irregular sleep-wake habits can make us feel irritable, moody, impulsive, and can affect actual memory and learning. We need sufficient and regular sleep in order to both take in information, produce new information, and to sift out what's most important from our learning. And lack of sleep or irregular sleep affects us physically, our physical health. And for example, we know that insufficient sleep is linked to obesity in children, particularly younger children, and heart disease and type 2 diabetes in adolescents and adults. So people often wonder, like, how much sleep do we need? And it's been a research question for decades, or certainly since sort of the mid-20th century. And we know that really children and adolescents, and as I said, adults need quality sleep to function at our best. Based on numerous studies now over the last 30 years, we know that children ages 5 to 11 or 4 to 11 require approximately 9.5 to 11 hours, and adolescents ages 11 to 18, or actually I would say 21, require approximately 8.5 to 9.5 hours. So how much sleep do you need as parents? And we know that most adults, certainly by our early 20s or mid 20s, sleep need is about 7 to 9 hours of good quality sleep. So there really aren't significant changes in actually the quantity of sleep that we need. A lot of people assume we need less and less sleep as we get older, and that's a real misnomer. But unfortunately, whether we're talking about children in foster care or children in general, children in the US and in numerous other countries are requiring insufficient sleep. And this is data from 2014. And unfortunately, during COVID, some of these concerns have increased. So you can see on this slide that, say, if we look at 6 to 11-year-olds, where we would say we recommend 9 to 11 hours of sleep a night, or even a little bit more than that, you can see that still close to 30% are not getting sufficient sleep. And in the 12 to 14-year-old age group, you can see that only 30% are getting a sufficient amount of sleep. But I think more importantly is how you as parents can determine or help to determine, whether it's on your own or with a healthcare provider, whether children under your care have a sleeping problem, or what can you do as parents to help your children develop healthy sleep-wake habits. And I'm going to talk in general, and then we're going to talk about the work that we're doing to learn about the specific needs of children in foster care and for foster caregivers. So A colleague of mine developed this kind of these sort of questions using the first letters of the word bear or bears. And these are just sort of good ways to think about whether it's when you're talking with the pediatrician themselves, or yourselves, to sort of start to think about what's your child's sleep like, or your children's sleep. So one, the B stands for bedtime. Does your child have difficulty going to bed or falling asleep? Does your child experience excessive daytime sleepiness during the day, meaning unable to stay awake during times that they should be awake, like in school? Do they awaken frequently during the night and have difficulty falling back to sleep? Are their sleep-wake schedules regular? We know that it's really important to have a regular bedtime, a regular wake time. And then finally, is your child snoring? Because snoring can be an indication of pediatric sleep apnea, although it does not necessarily mean that they have pediatric sleep apnea. So the next couple of slides talk about, how do we sort of prevent, or what are the things that you can do as caregivers to help prevent more serious sleep problems? So the first is to think about a regular, your regular screening when you bring your child to the pediatrician. And these are things to kind of think about, or being prepared to talk with your pediatrician about. In a way, I would say, regardless of whether the pediatrician, as I would say, should inquire about them. So is your child snoring? And to be able to talk about that. What are your child's sleep-wake patterns like? Is their timing regular, as I said earlier? Are they waking up a lot during the night? Do they have noisy arousals during the night? What's their functioning like during the day? We know that insufficient and irregular sleep, as I said at the very beginning, can affect school performance, can affect attention, can affect your child's sort of mood and personality, might affect even the development of complaining about headaches, and certainly hyperactivity. And also growth in both directions. For adolescents who are getting insufficient sleep, it can actually suppress the growth hormones that are secreted during sleep. And also insufficient sleep can lead, as I said earlier, to childhood obesity or weight gain. 75% though of sleep problems can be resolved. It's really important with just simply improved sleep-wake habits. So we recommend, and I put these books on the slide as suggested books, some of the books that I think are quite good by Mark Weisblath, this book by Joanne Cuthbertson and Susie Chaville that was written over 20 years ago, and you can still get it in print online, talks a lot about attachment and sleep, and Jody Mandel's book, and there are others. But certainly a relaxing bedtime routine is important for any child, and a consistent routine. Routines in general help to create quality sleep. Thinking about a bedroom being a friendly place for a child. You want for you and your child to sleep in a dark, quiet, and cool environment. And so thinking carefully about what kinds of night lights might be used, because too bright a light might make it difficult for a child to fall asleep. You might need to sort of wean them off of that, but think about it carefully. Once they're in bed, encouraging them to, if they're old enough, to read quietly, to listen to relaxing music, but certainly to take out all gadgets, cell phones, iPads, etc., out of the bed and bedroom. Avoiding large meals close to bedtime, and encouraging physical activity and outdoor light throughout the day, but decreasing very active activity close to bedtime. So what are some interventions if problems start to arise? We know that behavioral treatments work. In fact, 80% of children improve by some kind of intervention. And treatments or interventions are generally pretty short term. So I'm going to talk about a few kind of issues and some of the approaches. So how do we promote healthy sleep regulation? So as I've already said, an organized and consistent sleep-wake pattern is really important, and a consistent wake-up time. It's good to sort of try not to have that deviate by more than 30, 40 minutes. Keeping also a regular schedule during the day. And you want to have light exposure during the day, but you want to decrease light exposure at night. And that kind of helps to keep our biological clock in sync and regular. Age appropriate napping, of course. Not all children are going to nap, but it's certainly not uncommon for children to still require a nap up until around age 5. Sort of the kindergarten years. In fact, I think it's a misnomer that kindergartners don't need naps. There are some school systems around the country, in fact, that try to require napping for kindergartners. And I will move on. Oops. I think it's also important to promote practices that reduce arousal and promote relaxation. We know from some of our findings that you'll hear about later, and it won't be a surprise to you, that certainly children under your care may be anxious at night, may be easily aroused. And so thinking about reducing stimulating play at bedtime, certainly for older kids, but sometimes it comes about in other homes, eliminating caffeine. Chocolate is a bit of a myth. Little amounts of chocolate have very little caffeine. Thinking about calming activities at bedtime, as I said earlier, reading, listening to music, even for some older children, meditation kinds of practices might be helpful. Creating a soothing sleep environment. And again, keeping electronics out of the bedtime and limiting use probably a good 45 minutes before bedtime, because the light and the stimulation from being on an iPad or a computer in particular, particularly the blue light, can enter the visual tract and delay the onset of being able to fall asleep. So I included this slide because we know that 97% of adolescents in the US have at least one electronic device in their bedroom. So really thinking about, as I said earlier, the problems with having such devices, and thinking about ways that you can encourage better habits close to bedtime. Both the blue light exposure and even the radiation from cell phones can delay melatonin onset. Melatonin is what is secreted by the pineal gland and connected with what's called our biological clock, and can actually, melatonin peaks about a half an hour before we're going to most likely to fall asleep biologically, and troughs close to, this is naturally secreted melatonin is at its lowest levels about 30 minutes before our ideal time to wake up. And light exposure can delay the onset of sleep. So some of your children under your care may have more, I don't want to say necessarily serious, but have really problematic bedtime problems. So I want to talk a little bit about behavioral insomnia. And I'm going to talk a little bit about difficulty falling asleep and difficulty maintaining sleep. Children, just like adults, can develop insomnia. So, the symptoms might be arguing about going to bed, stalling going to bed, what we call curtain calls, as is suggested by the slide, one more hug, a drink, a snack, another story, another song, leaving the bedroom. And it's estimated that, 10 to 30% of preschoolers and 15% of kids in school up to age 10 experience some form of difficulty falling asleep. And then there can also be bedtime resistance, which is more conceptualized as kind of a parent-child interaction. It might include anxiety or fears. And again, our findings suggest, not surprising, that this is more common for children in foster care, but certainly true for other children as well. You might see non-compliance, temper tantrums, kids kind of suddenly getting a second wind. We use that as an expression, but it's not really a second wind. You've kind of passed their bedtime generally. And we really want to attend to a child's natural biological clock because it's going to vary from child to child. So sometimes bedtime resistance can just simply be that you're trying to get your child to go to sleep too early for that particular child. So what can we do to handle bedtime resistance? And here are just some recommendations, or what I would call kind of strategies. And they overlap with some of the things that I've said already. Keeping a regular sleep-wake schedule. That's true for all of us. Trying something called bedtime fading. So you might sort of, you might slowly, if you have a child who's resisting going to bed, you might actually move their bedtime up subtly a little bit later and then slowly back it into the time you think that's better for that child. Maintaining this bedtime routine and keeping the things the same. Some children, you really need to make sure that the order is even the same in any given night in terms of brushing teeth, washing up, and what you do as a family. Considering a transitional object if your child doesn't have one. Sometimes that can be helpful, a stuffed animal, a blanket, a t-shirt. Using positive reinforcement over punishment around bedtime. And one thing that's really important to keep in mind is you don't want to reward good behavior from during the day by saying, oh, you get to stay up late. We really want to kind of pay attention. That's easy for all parents to fall into that trap. Attending to when your child really is awake versus drowsy. Kind of pushing a child to, as I said, to go to sleep when they may really not be sleepy can be challenging. And of course, avoiding and engaging in arguments with your child, which of course is important at any point, but is particularly important around bedtime because it can produce more arousal and agitation, which then will make it even more difficult to unwind. And it sometimes can feel counterintuitive because you're so frustrated as a parent if you have a child who's resisting going to bed. Other children experience prolonged night awakenings. This is sort of another form of insomnia of childhood where a child wakes up and has trouble falling back to sleep. And one important message to keep in mind here is that children become accustomed to or often need to fall back to sleep in the same way they were put to sleep in the first place. So if a child has become accustomed to a particular object or a particular song, or you're needing to be present, then they're going to look for that when they wake up. This is particular for, preschool age and early elementary school age children. So this is sort of, again, the waking up and having trouble falling back to sleep is the inability to sort of initiate and maintain sleep during the night. And what I was talking about a few minutes ago is what I meant, sleep associations. Kids will have associations with what happened at the beginning of the night with what they need to fall back to sleep during the night. But again, most of the time, if you sort of think about changing how you're going to do things at bedtime to something that makes sense and helping the child learn to self-soothe, then they'll learn to self-soothe in the middle of the night as well. So want to talk a little bit about additional kind of interventions or approaches, particularly for children who have difficulty falling asleep at night or wake up and have difficulty falling back to sleep. I'm not going to talk about all of these approaches on the slide in the interest of time, but I'm happy to answer questions going forward. Certainly there's the old-fashioned kind of unmodified extinction, what psychologists refer to as unmodified extinction. That's sort of the cry it out. That's sort of the idea that you let the child fuss and eventually they will stop. That does not work for all children and can be quite exasperating for parents. So in more recent years, other approaches have been tried and are very, very successful. So one is something we call extinction with parental presence. And that's kind of thinking about kind of you're in the room first with your child trying to fall asleep. Maybe you have a chair by the bed, and you basically gradually over several nights or sometimes weeks move the chair in essence or yourself further out until you're really outside of the room in the hallway and then out. That's kind of a more gradual approach. I want to say a little bit about what we call the sleep fairy and the bedtime pass. The sleep fairy is kind of a similar concept to the tooth fairy. And I think it's kind of lovely and can be great when thinking about the concept of attachment. But it's the idea that your child, there's some kind of reward, whether it's pennies or chips that they get to turn in or something, that if they, you might start out by, it's X number of times they wake up, they're allowed to, and then you're trying to get without calling out to you, and then you kind of decrease it. But when they have those nights successfully, then the sleep fairy appears and there's something in the little jar or bucket. Bedtime pass is a little bit similar, but sort of in reverse, that you start out with your child gets a certain number of passes, so to speak, that they're allowed to call out to you, and you sort of decrease the number of passes that they have. So I'm happy to talk more about these various approaches. I did want to define nightmares and sleep terrors, and in a couple of minutes, I'm going to turn things over to Maddie and Josie. So I do want to point out the difference between nightmares and sleep terrors. Nightmares, and if we had more time, I would talk about the different stages of sleep, but nightmares occur in the last third of the night because they occur as a part of regular dreaming, as a part of what we call REM sleep, which stands for rapid eye movement sleep. And it occurs, other than in very young children, in children and adults, in more of the last third of the night. We spend increasingly more time in REM sleep, and so you're more likely to have a nightmare. Children often awaken from a nightmare and can recall it because the brain is closer to an awaking, is highly, is functioning very clearly during dreaming. Sleep terrors, which I'm sure many of you have seen in your children, actually occur during the first few hours of the night because they're a function of what we call non-REM sleep. Often in these situations, kids will be agitated, confused, disoriented, and they'll have amnesia. They won't really remember the event. And sleep terrors, generally, it's better to sort of you don't really want to wake the child up. You just want to soothe and calm the child back to sleep. I see there's a question. Let me just do this on one slide and then I'll answer your question. I do want to comment a little bit on medications, again, before I turn things over to my colleagues. And the reason I want to talk about it is because you're going to see from our findings that a lot of children are being given melatonin. Melatonin, does not require any kind of FDA approval in the United States, although in most other countries it does require approval, a prescription. And although it might help adults and adolescents to sleep, it is not recommended for children under the age of 16, or certainly for children who are not in puberty. And I'm happy to talk more about that during the Q&A. And finally, these are just questions that I think you should think about for children under your care. How many hours of sleep does your child or your children get? What might be some reasons your child isn't sleeping well or not able to maintain sleep? How does your child usually feel when they wake up in the morning? And what are some of your bedtime routines? It looks like there's a question, and then I'll turn things over to my colleagues.
Hi, this is Steve. Challenge, maybe you could just comment. The challenge is the foster child used to sleep with the birth mother.
Mm-hmm.
And so it's impossible to replace that
Right.
in the routine, because clearly it's not something we're going to do.
Yeah.
And so I just wondered if you had any comments about that.
You couldn't have picked the hottest question out there. We are well aware of this. You're going to see from our data that for children who are in foster care, one of the major issues is around anxiety and attachment, and exactly what you're talking about. And my colleagues and I was going to say something at the very end of our remarks tonight, and I've talked with Arnie about this. We are in the process, based on this data and some data we're going to collect from foster care staff and social workers, to develop some new recommendations and training specifically for foster caregivers and foster care personnel around issues of sleep and attachment. What I can say at this point is we believe, based on attachment literature, that working on kind of an attachment object, so helping the child to sort of develop what you would do with a younger child, a blanket, some kind of object that you sort of help them become attached to, that sometimes kids more naturally are attached to in other circumstances. So that's one kind of concept that we're working with. But you're right. I think that is one of the key challenges, and we are aware of this, and there has not been a lot of discussion about it.
Thank you.
Yeah. I'm going to turn things over to my colleagues who are going to talk about some data that we've collected, and then we will open things up for a discussion for the last 15 minutes.
Well, hello, everyone. I hope everyone can hear me okay. As Amy mentioned, my name is Josie, and just to wrap up this talk, we wanted to talk a little about our study. As Amy mentioned, from our study, we wrote 2 papers. The first one I will be focusing on, and then the second one my colleague Maddie will be focusing on. The first one was in regards to foster caregivers' perspectives, perceptions on children's sleep patterns and sleep environment. We wanted to start by talking a little about the methods. As Amy mentioned priorly, this was a collaborative study with researchers from the University of Houston, Fairleigh Dickinson University, and the PAJAMA program, which is a nonprofit organization. We distributed surveys. These were Qualtrics surveys via private foster care group chats in order to ensure validity to our study. The population that we were going for were children ages 4 to 11. And this was a survey that was distributed around the United States, and parents were invited to complete this survey. In the survey, we included both quantitative and qualitative questions, which focused on sleep patterns and emotional and behavioral well-being. Just a little about our participants. We had a total of 485 total completed surveys. The mean of the children was around 6.4 years of age, and it was around 50% female and male. And we had 81% level 1 or 2 care, and 72% of the caregivers were married at the time, and 72% of the caregivers reported that they had at least 1 college degree. So now we're moving into the quantitative findings. These were in regards to the sleep concerns. The foster caregivers are receiving minimal training and education about sleep, but are actually frequently seeking the sleep-based advice and or services from healthcare providers. And this was something that came up a bunch throughout the survey, and from what the foster care givers were telling us. Then we included a scale of 1 to 10 to rate the sleep quality, and it was rated that 6, around the mean was around 6, and this was mediocre sleep. And then compared to other children, sleep and schedule and duration do not differ vastly, but they have increased sleep-related problems. Around 12% report that their children took at least 1 prescription medication, and this could include things like clonidine or trazodone. And 50% of caregivers report having given their children over-the-counter medications for sleep, with the majority reporting the use of melatonin. This was about 91% of parents that are reporting the melatonin, and the rest of the parents could be using things like Benadryl, for instance. So moving right along into our qualitative findings, this came from open-ended questions. So here, my colleague Maddie and I coded for high frequency patterns. We looked at difficulties experienced by foster care children during sleep. And then the top 3 responses from this question were fear and anxiety, nightmares and night terrors, and environmental disturbances. Maddie and I coded for fear and anxiety together, as anxiety was used to describe the feeling and not a medical diagnosis. And as Amy mentioned, there are differences between nightmares and night terrors, but because foster care givers' parents were not being explicit about the difference in between them, we thought that it was best to group them just for these findings. And environmental disturbances can be things from noise outside in the street, kitchen noise, other kids making noises, and same goes for lights. And now my colleague Maddie is going to talk about the second paper.
So the second paper that we developed from this study focused on how are the sleep problems of children in the foster care system being addressed. So to just go over some key findings of this study, we found that only about 13% of foster caregivers actually reported that their foster care agency provided them with information about children's sleep. Now, despite this relatively small percentage, over half, so 55% of foster caregivers reported having spoken with a healthcare provider about their child's sleep. And among these caregivers that spoke with a healthcare provider, most of the common recommendations were melatonin, around 35%, keeping a consistent bedtime routine, around 22%, and then prescription medication, around 19%. So we asked a few open-ended qualitative questions, and one of those questions was, how do you help the children under your care sleep well? And the main theme that we saw in the biggest code was bedtime routine. And this really revolved around consistency around bedtime. So about 63% of caregivers reported bedtime routine. And then the second most common theme was books or reading, coming in around 37% of caregivers. And then finally, quality time. And some examples here are snuggling or cuddling. And there was a really big emphasis here on physical touch. So about 27% of caregivers reported quality time as helping the children sleep well around bedtime. And then just some conclusions from the study. So we found that foster caregivers perceive that fear and anxiety somehow interfere with the sleep of their preschool or school-age children who are under their care. And we also found that the caregivers are reporting that children require a bedtime routine, again, consistency, as well as reassurance of safety in order to sleep well and have a good night's sleep. And then finally, we are seeing that foster caregivers are acknowledging that fear and anxiety are somehow interfering with the children's sleep, and therefore they have developed some strategies to help them. So the big takeaway here is that sleep health of foster care children is an area that we must continue to study, as well as provide education and interventions. So that concludes our presentation, and we are happy to take any questions you may have at this time.
We're going to leave plenty of time for Q&A, like Steve's earlier question. I hope it's okay if I refer to you as Steve. And I'm really open to questions. What I want to say, just in a little bit more detail, what we're doing going forward, and I had talked with Arnie about this. My colleagues and I have applied for some additional funding, and assuming we get that funding, we will hear in a couple of weeks. As I said, we're actually going to be conducting an interview study that will mostly be interviews with foster care kind of social workers and staff and people who help with placements and work with you. we may do some interviews with foster caregivers to get at some additional kind of questions we have and questions we've been getting when we give talks like this, to help develop the curriculum that we're going to be developing going forward, or kind of intervention or prevention approach. As I said, even specifically in reference to the type of question that Steve asked. And we also will be following up we submitted, there was a link to this survey. So some of you may have, I was in touch ages ago with Arnie about it. So some of you may have been participants in the project, but one of the questions was asking permission to get back in touch with the 500 people that completed the survey. And about 50% gave us permission to reconnect, and we're planning on doing that. We have some additional follow-up questions. So there'll be an additional survey as well, probably in about 6 months. Yeah, Steve, and then Francis, and then Lisa.
So I'm a question factor tonight. The other thing I wanted to ask you about relative to medications is it's pretty clear the foster child has allergies.
Mm-hmm.
And we, of course, haven't had long enough to sort out the source of that,
Mm-hmm.
What she's actually allergic to, but
Mm-hmm.
it causes a great deal of postnasal drip and disruption.
Mm-hmm.
Do you have any recommendation or thoughts surrounding that? So that what it results is coughing and waking.
Sure. Well, I'm not an MD. I'm a clinical psychologist by training. So, I mean, I do think that's a good question for your pediatrician. But what I'll say is that generally, and this would be true for really anyone, something like that, treating the symptoms are more important than treating the sleep. What I mean by that is getting a handle on what the allergy is and treating the allergy, and that will improve the sleep in that case, where that seems like the primary problem. So, that's the best I can offer at this point. I think resolving what the allergies are and getting the right the right way to handle the allergies is really important. Because otherwise what happens is you start to treat the wrong problem. And the reverse is true as well. I should point out that, issues of, you may have children under your care who have been diagnosed with, attention deficit hyperactivity disorder or attention difficulties. And I will say that increasingly pediatricians are aware of the fact that they need to assess sleep as part of that assessment, because sometimes it's a primary sleep problem. And when you treat the primary sleep problem, some of the attention issues improve. Not for everybody, but sort of the reverse is what I'm saying. Francis?
Yes, sleepwalking. Do you have any insight on that and how to, protect against like injury or getting out of the house or things like that?
Yeah. So sleepwalking occurs. I didn't do a slide of showing you stages of sleep, but briefly, let me just say that we all, so children and adults spend about 2/3 of the night in what's called non-REM sleep. And there are 3 parts to non-REM sleep: stage 1, stage 2, and stage 3. And then we spend about 20 to 25% of the night in REM sleep. And that's where most of dreaming takes place. And that tends to be more of the latter third of the night. Sleepwalking is a parasomnia, and it takes place during non-REM sleep, because in fact, during REM sleep, our muscles are, for all intents and purposes, paralyzed. They're inhibited. It's not quite paralysis. There's a rare sleep disorder that adults can get called REM behavior disorder that is not seen in children, where you might act out your dreams, but we don't walk during REM sleep. So sleepwalking is generally harmless. What I mean by that is it's similar to a night terror in the sense that it happens during non-REM sleep. And you're right, the main safety concern is thinking about, can the child walk somewhere that's not safe? So it is important to think about, items that might be in their way. And if you wake up, just very gently, with not really waking up the child, carefully moving them back to bed. Waking them up can be very startling during sleepwalking, so you don't want to do that. You want to just kind of coax them back to bed, get them back in bed, and generally they'll fall back. They'll lie back down. You can see some increased sleepwalking if a child is highly sleep deprived. So thinking about, are they getting sufficient sleep? Because sleepwalking can actually increase if a child is not getting regular and sufficient sleep. Good question. Lisa?
Hi. I'd like to talk a little bit about, or get some insight about, the safety issue, which
Mhm.
was huge with my recent placement, because a lot of her trauma happened at night. And
Mhm.
so
Yeah.
when she entered the home, she had horrible sleep to start with, but also needing to lock the door, which of course for fire reasons and other reasons wasn't exactly the safe. So, I mean, I found creative ways to get around it, but it took a long time. It was extremely difficult for her. And of course, physical touch was out of the question. She did not want me in the room, but she wanted to know I was there. And it was really complicated.
Yeah, that's a complicated question, and I'm probably not going to be able to sufficiently answer. You're probably more of an expert at this point than even I am. And as I said, this is why we know that it's a big need, that we know that what is not being handled, where we haven't provided the best resources to people like all of yourselves, is around trauma issues and sleep, for sure.
And it's definitely bled into the academic performance, everything that you were saying. It was like a whole mood thing. It was everything. So you're absolutely.
Yeah, I mean, so a couple of things. I mean, one, obviously a child like that probably needs treatment for some kind of trauma-related disorder, possibly. But I think in terms of, and sleep problems are a symptom for even diagnosable, post-traumatic stress disorder. So, that can be partially the case. Interesting, just a side note, but you'll appreciate adults who experience post-traumatic stress disorder actually, when they go to a sleep lab to kind of get some help and to figure out what's going on, they'll often report, compared to adults who don't have PTSD, that they sleep better in the sleep lab. And the reason that is because they'll say they have lots of people watching over their sleep.
Yeah.
So I'm guessing with the child you're talking about, that knowing that you're there was huge. And then, as you said, figuring out a system where they feel comfortable with the door closed, but obviously they have to be open to it not being locked. I think thinking about how to, if it's a child that's sort of, well, really at any age, I think where you can have them help you to set up the room in a way that's going to be most conducive to their being able to sleep is probably, a strategy. Another strategy might be, thinking about, as I said, even if it's an older child, thinking about, well, what other kinds of things might help them feel soothed. Again, back to the attachment object issue. I think that can sometimes be something that was missing because of their earlier adverse experiences. And so kind of introducing it, even though perhaps the child would not be an age you would normally introduce.
Oh, that's funny. One of the
like
bad times I read her children's books and that worked.
Yeah. So, I mean, I think that, so that's the best I can answer at this point, but I think, you're spot on to this being, I think, one of the areas that we know we need to provide more help and services in.
Thank you.
Yeah. Julie? I'm just going along the top, but that's how they pop up in order.
Yeah,
My
I
top
have
of my
a question
screen.
that might be odd or basic. I'm not sure. So I have a little guy right now that was born 8 weeks premature. So I was partially wondering, I haven't been able to tease out an answer from any of the medical providers. At what point does their gestational age and their corrected age kind of align sleep-wise? And no one can sort of answer anything for me. And the reason that he's currently about 16 weeks and he's sleeping about 2 hours total during the day. And I don't think that's enough. And no one seems to think no one's helping, or they're just saying it's a baby. So I don't know how to advocate.
And
for
you
him in
must
a
be,
way
and
where
you
he-
must be exhausted.
So,
Um,
so, Ju-
a
so,
little-
Ju- so
So
Julie,
is-
I have bad news for you because my daughter sitting to my left was a premature child and had lots of issues at birth, and it was 3 years before she's leveled out.
Yeah, and that's, if somebody could tell me that, that would be fine. Just no one is telling me anything, so I can't.
I can't answer the question specifically because that's of course child specific in terms of matching the premature, the age to what age is. I mean, I guess the way that I would hypothetically look at it would be to measure sleep relative to what, because with a premature baby, there's still like delayed brain development. There's other things that are of course tied in with sleep. So I think one thing would be wherever the pediatrician is saying they think developmentally the baby is, that would be where I would view sleep. So you're right. You still really have a newborn, and a newborn is going to sleep in little tiny bouts of sleep, is going to sleep and wake up. That's not uncommon for, quite a while. That would be what I would say, at least for the time being. I'm happy to try to, I'm happy Arnie can let people know if they want to email me, and I'm happy to try to talk a little bit more with you one-on-one. It's hard really to fully answer that.
I'm sure.
Yeah.
Sure,
the other thing too, well, let me just say this, not all pediatricians are hip on sleep. I do highly recommend, I don't know, you're in different parts of the state, but as an example, in the Baltimore metropolitan area, we have a terrific pediatric sleep clinic at Mount Washington Rehab Hospital, run by Dr. Laura Sterney. She has a terrific staff and colleagues, and there are terrific places, throughout the state. Those of you who are closer to DC, there's a terrific pediatric sleep center at Children's National Medical Center, kind of really nationally known. So we do have good resources in this geographic area.
Okay, thank you.
Yeah. Catherine?
Great. Thank you so much. Really, thank you for this talk. I've been so excited about this one. So I have a little 15-month-old guy, and he has pretty much never slept through the night, and it's not a feeding issue. We haven't fed him at night for since he was about 9 or 10 months, but he wakes up at night. He goes to bed just fine, but he wakes up at night upset many times. Sometimes it's minor enough that he can soothe himself back, and sometimes it's much more severe and you have to go in and hold him or rub his back or touch him until he falls back to sleep. But being so young, obviously we can't take him to therapy or do anything like that. I was just wondering if you had any advice or suggestions. The pediatrician was pretty much no help and just told us to just let him be, but I can't when he's that upset at night, when it's more than just a little bit upset.
Well, that's why I was using some of the, there are different strategies. And, that's going to be a couple of things. Number one, yes, that's sort of the old school of saying, well, just let the child cry it out. I think paying attention, one thing I would pay close attention to is what is your routine, bedtime routine at night. It's possible that kind of by accident, you have some kind of part of the routine that then when he is somewhat aroused at night, he's looking for whatever was the routine at the beginning of the night. So sort of trying to think about that a little bit sometimes can be helpful. At 15 months, you can start to think about like the gradual method. So even though he may be very aroused at night, thinking about how to kind of start a routine with him where you are doing what you're doing, and then to kind of fade that out in some way. So they're really different approaches. I guess it's, again, at the individual level, different strategies work for different parents. There are strategies in all three of those books that I've mentioned on the slides where there are recommendations. That's not it's hard for me to know whether that's, you're right, you can't have them be in therapy and not knowing the circumstances, but for a young baby like that, I think using some of the behavioral approaches makes sense, but you're going to have to adapt them according to his needs as well. I'm sorry, I'm not being very specific, but it's hard without, one-on-one.
No, that's helpful. And we did recently get him to attach to a stuffed animal. He was not a pacifier guy, and that has
Yeah.
helped some. And so sometimes it's just giving him back the stuffed animal if he can't
Yeah.
find it.
I mean, it sounds
but-
like you're going in the right direction, I have to say, from everything you've said. And it could also be that you don't realize it, but in the moment, I would pay attention. It's possible he's having a little bit of a parasomnia, and in which case getting him I would pay attention to just how aroused he is, and whether by accident, and I'm not trying to, assume anything. I don't mean this in any negative way, whether he's getting a little more aroused. So you can sort of kind of watch that really closely. He may not be as awake as you think he is, I guess is what I'm trying to say.
No, that makes sense. Yeah. Thank you.
Yeah, you're welcome. Christina? Oh, Julie, and then Christina. Oh, Julie, did I answer your question already?
Yes, you answered mine already.
Christina.
Hi, yes. So I have a 2.5-year-old boy that he has been with me over a year now. And we're kind of finishing up like potty training. So he's fully in underwear during the night as well. But he has the episodes, like the one before me had spoken. He'll just wake up. Some nights he'll only do it once or twice. Some evenings he'll do up to 5 or 6 times, where he will wake up like screaming or crying, and sometimes he'll fall asleep by himself. Sometimes he won't. So can that be coincided with maybe him needing to use the bathroom, or could that stem from something else?
Yeah, I mean, I'm not sure, again, without knowing more the child better. Certainly he's in the midst of a developmental change, so that could be challenging. And, he's still young, boys, this has nothing to, boys in general are potty trained later than girls. So, I thought you were about to say that he's, wet at night. And of course, a 2.5-year-old boy, that's just typical. It could be related to that. He could be having some kind of arousal or parasomnia. So again, as I was saying to Julie, paying attention to just how is he really awake, and or is he sort of becoming more aroused because you assumed he was awake. So sometimes that can be startling and create some emotion. And it sounds like this has increased since potty training. Is that what you're saying?
Yes.
Yeah.
He might
So-
go like a week or two where there's nothing, and like his dry bed in the morning, but then some weeks he's up 5 or 6 times.
Yeah.
And
So
it's
it sounds like this could be a bit of a transitional issue. And so thinking about how to not turn it into a problem, which sounds kind of, sometimes kind of trying to think about, well, what can we do to not sort of turn this into a new problem, but recognize that the transition is a little harder than you initially thought it was going to be.
Okay, well, thank you.
Yeah, okay. And again, the same things I was saying, I mean, thinking about some of these, again, he's old enough to use some of the kind of ideas that I was suggesting, not so much the sleep fairy, but thinking about a kind of gradual extinction. These are really great questions, and it's hard in one evening. So Arnie, I'm happy to come back. It's hard in one evening to answer some of these really these questions, but I'm well aware of the need. Any other questions or comments or suggestions? Steve? Do you go by Steve or Steven? Sorry.
It
You're
doesn't
on
matter.
mute.
I do both.
Yeah.
I always write Steven so that people don't put a P in my name. But I guess this is almost a comment. So during the day, there's preschool, there's my daughter, there's adults, there's eating, there's activity, right? And it seems like though we have a really good routine and we quiet down, that's great. But now that we're all calmed down and the day has slowed down and everything's getting really slow, the reality of the fact that she's not home, right? And what's happened kind of like seems to show up, right? In a larger than life way, right? It's kind of like the one point at which, and so all the things that you're saying are really good, and we've got these routines and we read books and we have a little cuddle and all this is happening. It's just that the very act of getting her calmed down to go to sleep is causing this other opening in her mind for all this other stress.
So it's not
So it's
uncommon.
all-
Yeah.
That's
Yeah,
all.
well, no,
And I
just-
don't know what to do about it.
well, I do actually have a couple of thoughts. What I'll just say, what I will say is that, in general, all of us tend to, at the end of our day, have, as adults, if you think about it, we have thoughts, we have things that are on our mind for the next day. And if we have kind of particular life circumstances, those might be more exaggerated. How old is your child?
She's 4.
Okay. Yeah, so she's old enough to, have a lot of thoughts, right? And so one suggestion that I do have would be to what they call set aside some time that is sort of for whatever that is, whether it's drawing a picture or something that kind of lets the thoughts out a little bit. It's the same way we tell adults to jot down, a good, sort of 30 minutes before you're going to really wind down, or even more than that, 45 minutes, take a pad of paper or, wherever you're going to put the kind of notes, and then say, okay, I've set them aside. So actually acknowledging it with her since she's 4 is probably fine to do, and to kind of say it out loud for her, and then to give her a way to kind of release that in some way before, sort of to be ahead of her on it, I guess is what I'm saying. And that is a strategy that has worked for some families. So that's what I'll say for now.
Thank you.
Well, an hour went by very quickly, and I thank you, Amy, and your colleagues for your time. I'm not going to try to pronounce their names and mess it up, so thank you. I see Lisa popped up with one more question. Do you have a question, Lisa?
No, it was just clapping for a great presentation.
Thank you. And please remember, if you want credit, put your name and jurisdiction in the chat here now as we're wrapping up. So, but I can pretty much see everybody stayed the whole way through. So thank you all for being here. We will put this recording and the PowerPoint presentation up on the MRPA.org website under the resource tab. It probably will not be up before the end of the week, but just so you know, it will be up soon. And I thank you all very much for joining. Please also, if you want to, you can email us at information@mrpa.org if you have any ideas of other subjects you would like us to address. We've talked about some fun ones across the course of the last couple months, social worker shortages. Now we've talked about sleep. We've talked about taxes and tax credits and those kind of issues. So this program is geared to addressing things and ideas, issues that you would like to hear more about. So once again, thank you, Amy. I do hope to circle back with you soon, and I do have some other ideas about ways we could use your information and your presentation. So
well, my pleasure, and thank you to Maddie and to Josie for giving us their time with me tonight. And yes, I'm happy to, I'm around. I'm happy to make this annually or multiple times. Yes, and I will email you my slides, our slides.
So thank you all very much. I hope you have a great evening. Thank you for being an incredible audience and for great questions. And with that, we will adjourn, but please make sure you get your name in the chat. And like I said, Amy, I'll be back in touch with you. I have another venue, I think, that would be excellent for your information.
Okay, my pleasure. Always happy to talk about it. So anyways, have a wonderful evening. I didn't say
Thank you,
I'm a parent
everyone.
too. I didn't say that. Okay, take care, everybody.
Thank you and good night.